This is the Trendelenburg gait.
Alright, so some characteristics of Sanspace are weak glute med and weak abductors, pelvis drops on contralateral side, as well as with lateral trunk bending. So Paul is going to demonstrate.
So I have Trendelenburg. I have a weakness on my right side. So you'll notice that when I walk, when I take a step with my right and I'm standing on my right, my left hip is going to drop. And you'll also probably notice that my trunk's going to lean over. So generally when somebody has this weakness, they'll drop the hip and kind of lean the trunk to compensate and get their center of gravity over their base of support.
Okay, we are for this Trendelenburg gait, we're using the Snetti balance assessment tool, which is a tool that assesses fall risk, and we observe the gait in a normal pace, which we just observed, and now he's going to do the fast pace. And now we'll go through what he is lacking and makes him at risk for falls.
Ready?
Ready. I'm
Okay.
ready to watch. I'll just go highlight what he was, what really stands out to me. He's at a moderate at risk for falls. That score is between 19 and 23, and so during his fast pace, as his pace increases, his step length decreases and becomes more step 2 instead of step through. His step symmetry is not equal. His step continuity is discontinuous, and he has marked sway when he walks. So those are the highlighting factors that makes him moderately at risk.
Going.
Okay, so one type of strengthening exercise we're going to be doing is to strengthen his abductors. So we'll have him standing and then using a TheraBand, and he'll just bring his leg out. So go ahead and bring your leg out, Paul, and then bring it controlled in. Cool.
So another workout we're going to be doing for the hip abductors is going to be your sideline hip abductors. And what you're going to be doing is you want to keep the patient's spine in neutral position, and you're going to want to raise the leg up sideways, give a little guide along the ankle, bring it up, and then you're going to bring it down slowly. Another variation, if that's a little bit too difficult, is to bend the knee, like so, and lift it up like that. Another variation is to keep the foot on and kind of do clam opens. And you bring the knee open. You want to make sure that the hip does not rotate when you're doing this as well.
My name is Anthony Rosales. I am a physical therapy assistant student for American Career College, and today I'll be talking about 3 gait abnormalities: the Trendelenburg, the hemiparesis, and hemiplegia. But more specifically, I'm going to be going into the pathologies and reasons behind how this occurs. So with Trendelenburg, a couple different pathologies include, with children specifically, are congenital dislocation of the hip and congenital coxa. Now with coxa, that is a lesser degree of the neck of the femur. So normally in children it's about 135 to 145 degrees, but when coxa occurs, there's about a degree of about 110 to 120. So the leg length discrepancy or difference when you see them do their gait patterns is noticed. And some of the causes of this could be rickets or fibrous dysplasia. Going back into other gait abnormalities, pathologies for Trendelenburg can include, when it comes to coxibera, it can also come from leg calve perthus disease, if I'm saying this correctly. That's the weakness in the extension and abduction muscles specifically. And what happens is there's an interruption of blood supply to the head of the femur, which that in turn causes fracture in the supporting bone, and then eventually, usually there is ossification, which causes the bone to reheal, but sometimes that doesn't occur, and there is some subchondral fracture, which changes the epithelial growth plate. One more of the pathologies with Trendelenburg include the proximal femoral causes fracture in the supporting bone, and then eventually, usually there is ossification, which causes the bone to reheal, but sometimes that doesn't occur, and there is some subchondral fracture, which changes the epithelial growth plate. One more of the pathologies with Trendelenburg include the proximal femoral physis, which is the growth plate. This is also affected, which causes other abnormal structural changes. Diagnosis testing includes radiograph to see if there's any displacements.
The next gait assessments we're going to be talking about are the hemiplegia, which is a neuromuscular dysfunction that radiates down the lower extremities where it causes no muscle activation. And the next one is the hemiparetic, which is also a neuromuscular dysfunction, but it radiates down the leg, but it also gives a little flaccid and spastic muscular activation in that affected limb. Please note that the hip is into extension, knee into extension, the affected foot internally rotated, the lower extremity circumducts, and the plantar flexed. Going.
Okay, so we'll see here with Jackie's gait. She has a hemiparetic gait. Remember, with hemiparesis or hemiparetic gait, there's a little bit of muscle activation. So you can see that she's actively circumducting her hips versus just dragging the extremity. And if we turn her around, there's a lot of variations because it is a neuromuscular impairment, so it depends on the level of spinal cord and the level of the injury. There's also variations per patient. Sometimes you'll see them drag the lower extremity because they have no use or activation of the muscles needed. So when performing the balance assessment for Jackie, I would put her at a high risk of falls on using the Tinetti balance assessment, just because she scored above a 24. You can obviously see the impaired pattern. She's stepping 2. She has a little bit of a trunk lean when she moves. Her steps are discontinuous. It's not a fluid movement. And her step length is severely affected on her right side. So those are just some of the factors that would cause her to score so low on the fall risk.
Now moving on to hemiplegia, which means paralysis in one half of the body, and that the most common reason for this is stroke. So stroke is insufficient blood supply from the brain to the brain, which can be caused from a thrombus, a clot, or a hemorrhage. Other reasons behind hemiplegia could be vasculitis, which is inflammation of the blood vessels, cerebral palsy, which is lack of blood supply to the nerves of the brain. Reasons behind this could be from trauma or a difficult birth. Other pathologies include leukodystrophies, which is damage to the myelin sheath of the nerve, which is kind of like the covering of the nerve cell. And this one's more rare. And then there's also diabetes, brain tumors, and meningitis. Now, I'm not going to go too much into hemiparesis because hemiplegia and hemiparesis, their reasons are pretty similar. Hemiparesis is more of a weakness versus paralysis of that half of the body. But again, the most common pathologies for hemiparesis is stroke. And that's it. Thank you.
Okay, so for the hemiparetic or hemiplegic gait, one of the things that we can do is try to get the nerves to fire back up again, trying to get the neuroplasticity and just the signals from the body to go back up to the brain. So what we could do is with her unaffected side, we can have her just do knee flexion and extension, and she's really not going to be able to activate her right and affected leg, but we're hoping that it kind of starts firing and getting used to those old movement patterns so that we can get a little bit more muscle activation. So that would be one of the exercises we can do. We can guide her foot here, make sure that it doesn't slip off because she doesn't have control of it. So that would be one. And then the other one we can do, or the other thing we can do to treat, is because of the tightness. She's flexed in her upper extremity. Her lower extremity is internally rotated. So we could just abduct and stretch those abductors, the internal rotators. We can externally rotate her foot to get a little bit more of a stretch. And then the same thing with her upper extremity as well. Just take it, and as much as we can, just go into elbow extension so that we can stretch out her biceps and her forearm, an anterior compartment of the forearm.